Welcome to live Q&A with the experts of Rome Foundation. My name is Tanya Murphy, Rome Foundation's Executive Director, and today's session is titled Sex Differences in IBS. I'd like to introduce my co-host, Dr. Douglas Drossman. Dr. Drossman is the CEO and President Emeritus of the Rome Foundation, President of the Drossman Center of Education and the Practice of Biopsychosocial Care. Dr. Drossman is also Professor Emeritus of Medicine and Psychiatry at the University of North Carolina at Chapel Hill. He is the founder of the Rome Foundation and is an internationally recognized scientist, clinician, and educator in DGBI and communication skills training. Today, Dr. Drossman is joined by our Rome Foundation board member, Lin Chang, who is amazing. And she is the professor of medicine in the Division of Digestive Diseases at the Department of Medicine at the David Geffen School of Medicine at UCLA. She serves as the co-director of the Oppenheimer Center for Neurobiology of Stress, and her expertise is in functional gastrointestinal disorders, including IBS. I'd now like to turn over to the esteemed Dr. Drossman.
Okay, Tony. Lynn, it's great to have you. Gosh, we must go back 30 years, so we are not only colleagues and researchers together, but we're very good friends, and I've always valued our communication and our work together and our shared views. And the whole field of DGBI and IBS is growing continually, and we continue to have this value of studying sex differences, which is often underrated and often open to bias. So that's what I hope we could really cover today. Lynn, by the way, is a member of the board of directors of the Rome Foundation for many years and works together on many, many projects within the Rome Foundation, in addition to her work with AGA and her UCLA and the like. And you're taking out time for this, so I appreciate it. The title is Sex Differences in IBS, and maybe the first question would be, what are the main differences demonstrated in the prevalence and clinical symptoms of IBS and other DGBI? I know that when we look at these prevalences, sometimes they may differ depending on the organ system involved.
Yeah, first of all, thank you for having me. It's really a pleasure to be here, and I do like talking about this topic. It's a topic that is near and dear to my heart in an area that our group has been studying for a number of years. You know, so there is a difference on, we can call it sex/gender differences, because sex is more biologically based on anatomy, the chromosome, the physical traits. And then gender is really the multi-dimensional construct of how individuals signal themselves to others based on behavior and also kind of could be based on masculine and their appearance and femininity. And I believe that there's both sex and gender differences in DGBI and IBS, and I study IBS more. But if we're going to look at the prevalence of women to men, and this has been recently reviewed by the Rome 5 Committee on Patient Perspective, Gender, Age, and probably not to anyone's surprise, almost all of the DGBI are more prevalent in women than men, including IBS, chronic constipation, functional dyspepsia. The only one that is more common in men than women is functional diarrhea. So diarrhea tends to be more common in men, that they will have diarrhea more than constipation, while women will have more likely to have constipation than diarrhea compared to men. But I would say one thing is that if you look at the general population, the male to female ratio is closer to being 1 than if you look at the healthcare seeking population. So women tend to seek healthcare more than men, and definitely it applies to IBS and DGBI. So from a healthcare provider standpoint, I think our perception is that we see more women with these conditions than men.
Do you think, is there a difference in the health care seeking by condition? In other words, would one condition bring women more in than men to the doctor?
I don't know that answer that question. I think it's a good question. It probably in general women, even outside of DGBI and GI conditions, do seek health care more than men. One question is for abdominal pain, which tends to be the symptom that drives patients with IBS into the doctor's office. Is it equal, or do men have to have, do women and men have a certain level of pain and then women seek healthcare more? Or is their pain level different and so then they seek it equally? I mean, I think that's probably multifactorial, but in general, I would say that women will seek healthcare more than men.
Is this related to hormonal differences between men and women, or are there hormonal differences that influence either the prevalence or the severity of the symptoms?
Hormonal differences have been studied more in IBS than the other conditions, but some of the scientific evidence that supports there is a hormonal influence on DGBI and also the perception of GI symptoms is, and this has been shown by Mark and Heidkamper and a little bit more recently using these ovulation apps, that during the menstrual cycle phase, so this is premenopausal women, so the first part after menses, then you have the follicular phase before ovulation, and then after ovulation is the luteal phase, and then you have your menses again. So that's the menstrual cycle phase. So estrogen increases during the follicular phase and goes down before ovulation, and then it increases again more broadly, and progesterone then increases during the luteal phase. And if there's no pregnancy, then in the late luteal phase, right before a woman's menstruation or period, the estrogen and progesterone will fall. And it's that withdrawal and the fall that is associated with increased GI symptoms in healthy women, but also in women with IBS. But the intensity and the severity of it's going to be higher in the IBS population. But it's that withdrawal of estrogen and progesterone that tends to have the looser stools, because estrogen and progesterone have an effect of relaxing smooth muscle in the gut, and it can slow transit time. And that's probably one of the reasons why women are more prone to constipation than men. But when you take that brake system off, you can actually have looser stools right before menses, because you have that fall of estrogen and progesterone, and it also is when bloating goes up, abdominal pain can increase. So it's really at around that time, right before menses, in the first beginning of the period, and then it goes back to its normal state. The other interesting fact is that when progesterone and estrogen are higher in the mid-luteal phase, women who tend to have constipation, they can actually be more constipated because of the higher estrogen, progesterone. And then also, an interesting study by Leslie Houghton some years ago is that she did rectal balloon distension studies at different times of the menstrual cycle and measured rectal sensitivity, and found that the one time in the menstrual cycle that women had lower thresholds for pain is in menses. But the other phases didn't matter as much. They were similar. So during menses, when your estrogen and progesterone are lower, you have greater rectal sensitivity. That goes in line with having more symptoms. And there are some differences in the postmenopausal women versus premenopausal, although there isn't that much data. I mean, we found that the severity could be higher in postmenopausal women. But what's interesting in the Rome Global Epidemiology Study, which of course you're familiar with, a lot of people are familiar with a large number of subjects and individuals, younger men and women will report a greater frequency of a lot of GI symptoms than older individuals. So there's an age effect. But in postmenopausal women compared to premenopausal women, postmenopausal women will report more of like outlet symptoms. So it might be more pelvic floor related.
I want to get into the issue of pain. You talked about the healthcare seeking is greater in the women. What about the experience and reporting of pain and discomfort of women to men? And what determines that? you attributed some to hormonal, but what about cultural factors, gender, socialization, things of that sort?
So women will report higher levels of pain than men, abdominal pain than men in DGBI, and that's been shown in multiple studies. And what's interesting is in some of the Asian countries, as you know, they report less pain and more discomfort. And if you look at the prevalence of IBS, for example, it'll be more men than women, or more equal men and women in certain populations, but it's more in Asia. So there's likely a cultural difference as well. There might be, diet and other factors that are more that play a role. But in general, women have more chronic pain syndromes and disorders than men. So if you look at the comorbidity of IBS or DGBI with fibromyalgia, which is a chronic somatic pain condition, migraine headaches, interstitial cystitis, that's going to be more common in women. So women in general will have more of these chronic pain conditions that are considered more somatic conditions or functional syndromes.
So IBS may be similar, but when you add POTS or mast cell activation, small fiber neuropathy, these are mostly women, aren't they?
Yeah, they're more common in women. And also, if you're going to have more comorbidity, you're probably going to healthcare seek more. It doesn't mean that you're necessarily going to go to a GI clinic or only seek for GI assessment in primary care, but you're going to see all these other subspecialists as well. But I did want to make a point about our rectal balloon distension studies that are one way of measuring abdominal pain, which is not a perfect system. You don't use it in clinical practice. But there's studies to show that men and women will have similar pain discomfort thresholds at baseline with IBS, but in general, IBS definitely have lower thresholds. They show evidence of rectal hypersensitivity. I think what's different, and I was looking at this based on a study I did years ago that I almost had forgotten, but you can have a baseline similar pain threshold in men and women with IBS and healthy men and women. But when you do something called sensitization, when you give like a noxious sigmoid stimulus, both healthy women and IBS women will have a lowering of thresholds, meaning they get more sensitization of their visceral afferent fibers, and then men do. And they both do, but women in general with IBS have lower thresholds. I was thinking if this is also related to why women are more likely to get post-infection IBS. So they get a food poisoning or a gastroenteritis when they had no previous IBS symptoms, and then the infection clears, and then they have IBS symptoms. And there's different factors that predict who gets post-infection IBS, but women are more likely. But I was wondering if infection in the gut, which is an inflammatory immune activating response, increased intestinal permeability, if that's more of a peripherally sensitizing effect and in the enteric nerves. And I was just wondering if that could be one of the reasons why women are more predisposed to getting post-infection IBS.
More prone to get sensitized.
Yeah.
Yeah. I think I remember decades ago animal studies that tended to show that too in the rats or mice.
Yeah.
What about the family or cultural influence on girls versus boys reporting pain? How much does that play a role, or is it there?
There's been some studies where they looked at different ages, and it's hard in children to determine, especially with like babies, to determine if there's a real difference by pain. One study looked at colic, but colic may not be necessary. We may not understand exactly what that's due to in babies. But when you get to post-puberty, teenage years, and you can get the individual to report symptoms, that's where you start seeing the female-male difference, where you have more predominant girls and women to boys and men. And then if you look at, for example, constipation, that tends to be more in women, and that tends to, you see that in the family, and it's more of the women in the family that have constipation. So there's definitely a genetic and familial predisposition to these conditions.
Familial in terms of family attitudes and behaviors toward responding to the pain reporting.
Yeah. and just managing or being more perceptive about their GI symptoms that maybe even extend outside of pain.
Or the attention to it too.
Right, the attention to it.
Well, then the last thing I want to cover is treatment. Do you think there are differences in treatment between men and women? I guess we'd have to go through a litany of different kinds of treatments, but can you give a general perspective on that?
Yeah, I remember, and you remember, over 25 years ago when Olocitron first came out, the 5-HT3 antagonist for IBS with diarrhea, that women in general will participate more in clinical trials than men. This is in IBS and constipation as well. So you have more women, and they found a statistically significant difference in placebo and Olocitron in women, but they didn't see that in men. But they didn't know if it was really due to the smaller number of men. I did a male-only study in IBS diarrhea that did show benefit in men. The results, even though you're not doing a direct comparison, looked more robust in women than men. And so the FDA also put a lot of attention, is there a different treatment response in men and women? But in general, sex and gender differences haven't been studied that well in different treatments and haven't identified, and this could be different reasons, like you don't have enough men to compare to women, that there is a treatment difference. There's some evidence that there might be some differences by hypnotherapy, that directed hypno, that men will respond more than women, but I don't think that's been well studied. And outside of the DGBI literature, and you probably know this better than me, there is some evidence that there's a sex-gender difference in the treatment response to neuromodulators. So in this one review, now this is a lot of, like, say, depression literature, so it's going to be higher doses than we use in DGBI, but that men respond more to tricyclic than women, and that women respond more to SSRIs than men.
I want to get back to this diarrhea constipation thing. You mentioned that women are more prone to constipation and men to diarrhea. What about with IBS? Does that go with IBS-D and IBS-C? That more males have IBS-D than women, and more women have IBS-C.
So there's different ways of thinking. For IBS-C or in chronic constipation, definitely more women than men that have that. If in the IBS population, the IBS-C subtype, you don't find that many men with that than women. If you look at the mixed bowel habit, where you have both diarrhea and constipation, it tends to be more women than men. But if you look at the IBS diarrhea, it's either a little more men than women or a little bit more comparable and equal. So I don't know if I would, so functional diarrhea is more common in men than women, but when men have this altered bowel habit, they tend to be more the diarrhea, where women can have all of the types, but they're going to have more constipation than men. And they've shown that in healthy individuals, that the motility is decreased and transit time is slower in women in general than men, and that's without constipation or IBS. And it may be hormonally related, since estrogen and progesterone slow transit time. So like if you see a pregnant woman, they can have GERD, and they can have constipation even early in the pregnancy when they don't have a large gravid uterus, and it's likely due to the high progesterone level that can relax smooth muscle, so the lower esophageal sphincter can relax, you have more reflux, slower transit, they can have constipation. So you can see that, and they have much higher levels of hormones, so it's a different state than just our regular cycle that we have in women who are not pregnant. But I definitely think there's more of a hormonal effect than I think that we all think about.
Yeah, I guess what I'm hearing is that there's more of an equalization between men and women, except during menses. But when not in menses, prevalences and responses are very similar, except for healthcare.
Well, we don't know that from the clinical standpoint, because it's not from a clinical symptom standpoint. It has been studied at different times of the cycle. I was giving you information on like a couple of studies and on the rectal balloon distension, and then also you're not necessarily. I don't think we always ask in women about the change in symptoms with the menses, and there's also data by Mina Rao looking at humans and in rodents, that androgens also play a role in transit time and in IBS symptom severity. So even women and men with a lower testosterone level will have slower transit and higher IBS symptom severity with lower testosterone. So androgens look more protective, definitely with transit time, and potentially with pain, but we don't know that as well. And I don't think estrogen levels have been really highly correlated with abdominal pain, because there's different estrogens and androgen metabolites, and they haven't been that easily studied, other than estradiol and progesterone in clinical labs.
Well, with that in mind, looking at the future, what do you think are the research opportunities in this area of gender-related symptoms?
I do think that studying postmenopausal women experience on DGBI compared to premenopausal is important. Also the perimenopausal, that's understudied. I think it's more the biologic basis of why we have these sex and gender differences is still needed. So we've done some brain imaging studies to show that the way men and women respond to a task or stimulus is different, or to treatment, which is really interesting. So it's not, there's probably there's obviously gut-related factors, but there's also central factors that influence the perception of symptoms and behaviors. And then also, one area that I'm very interested in now is how does the microbiome affect estrogen and androgen levels in the body? So there is evidence that so microbes make this enzyme called beta-glucuronidase, but there's hundreds of beta-glucuronidase, and some of that enzyme will convert a conjugated sex steroids, like androgens and estrogens that are conjugated, to unconjugated forms. And it's the unconjugated forms that are reabsorbed. Now, some of them probably are excreted, but they can get reabsorbed, and you can find them in the urine. But what's interesting is, so one area that we're looking at is in postmenopausal women, there's some evidence that the diversity of the microbiome is reduced. So the question is, do they have less of that enzyme? Do they have less of the deconjugation of estrogen, and then they don't reabsorb, so the level is different? And then could you even target the microbiome to change levels of sex steroids? Is interesting area.
Interesting.
Yeah.
Well, any last words? Thank you for doing this. Any last words or comments?
Well, one, I think that clinicians should think about that there are sex and gender differences that could be influencing the patient's experience. Like, just for example, did symptoms change during menopause or after menopause? Does it change in the menstrual cycle phase? Do you have associated premenstrual syndrome or other other disorders that are also hormone related, or thinking about endometriosis or ovarian cancer, some of those kind of questions. And then also for research, there has to be more studies where you're looking at gender identity, which we don't look at as much, right? We just say men, women, don't want to disclose, but really doing more of this span of gender identity. How does changes with transgender men, transgender women, affect these DGBI, and also recruiting more men to studies. It's not easy to find men with DGBI that are doing the studies, but you're not going to really understand sex and gender differences if you don't have more comparable numbers of men and women in your studies, and also healthy men and women.
Thanks very much. That was great. Very interesting. And Tanya, do you want to have any final words?
Yes, I found that extremely interesting, because even though you hear about a lot of all this, and sometimes your physician may touch on a few of these, but it really validated, especially, and I hate to take a side, but for women, what we go through biologically throughout our lives and the different phases, and how much this really impacts us with everything else we have ongoing within our body. it really makes me, again, feel validated in discussions you have with friends over the year or colleagues about what's really occurring. And I think this is a really impactful discussion that a lot of women can really hear and really feel some hope that they can move on with things.
It's really getting attention, but estrogen is so complicated. In some ways, it increases pain. Sometimes it decreases pain, and it probably affects what time of life that you're in and
Yeah.
what's your survival and advantage.
Right.
And that's what makes us very resilient individuals. So we just kind of touched the surface, to be honest.
Right.
But it is a fascinating area, and I think there is growing interest in this area for DGBI.
I think so as well. Thank you so much, Lynn, for joining us today. Thank you, Dr. Drossman, as always, for your expertise and leadership. Thanks, everyone, for viewing. Have a great weekend.
Thanks, everybody.